Good afternoon, everyone, and welcome to our session on public health data. We've been planning this session since the start of the year, and we're amazed at the interest this topic has generated. It highlights the level of interest data science, programming languages more generally has in public health, and certainly the role it has in data analytics. I'm Mark Williams, and I'm the Senior Advisor within the data programme, working on anything from data standards, advanced predictive analytics, and also performance management support that the LGA provides to councils. I'm very fortunate to get to speak to many people across the sector and hear what councils are achieving, and I get to share that work with everyone. The purpose of this session, though, is to showcase to the sector the value of preventative analytics, allowing councils to bring to the table options and discussions on ways to do things better. In particular today, I am joined by Dr. Adam Briggs, who is the Deputy Director for Public Health, Oxfordshire County Council, who will share with us a valuable presentation that we should all take a great interest to. I'm very grateful for Adam today for the commitment. Afterwards, we get to hear directly from two councils who will share with us today some of the most remarkable work. Rebecca Allen, who is the Head of Public Health Analytics, and Kathryn Loxton, who is the Senior Public Health Analyst at Suffolk County Council, will share how they use SQL, population health data, to drive targeted suicide prevention initiatives in their community. Then, on top of all that, Jasjot Saund, who is the Public Health Registrar at the London Borough of Lambeth, and they will share how they used R to model survival outcomes in individuals without NHS health checks versus those which have had the check. Finally, for anyone joining live with us today, there will be an opportunity for questions and answers. Please do put your questions in the chat and we will do our best to cover as many as possible. We do have a good variation among our audience today, from analytical experts looking for specific lines of code to strategic leaders looking to impact on the impact. So our presentations today will have something for everyone. Without hesitation, though, our first speaker today joins us from Oxfordshire County Council and brings a wealth of experience to the table. Not only are they the Deputy Director for Public Health at Oxfordshire County Council, but they are also the Director for the Public Health Programme at the NIHR. In addition to this, they are Professor of Public Health at University of Southampton, yet still managed to find time to be here this afternoon with us. So please give a warm welcome to Adam. And Adam, over to you.
Thanks, Mark. That's some introduction. Yeah, it's really lovely to be with you all, and it's an absolute pleasure to have the chance to talk about this topic. So I'm going to talk about it from two angles. One is in my role at Oxfordshire County Council, where, as Mark mentioned, I'm Deputy Director of Public Health, and one of the responsibilities I have there is not only looking after our health and intelligence team, but also the council's research function. And then I'm also, in my role with NIHR, going to talk a bit about how NIHR is really supporting research that uses a data-led approach to public health and primary prevention. So I will share my slides and make a start. And as Mark says, please do put questions in the Q&A function, and whilst I won't get around to them whilst I'm speaking, I will look to pick up anything there directly afterwards. That should be working now. So how data in public health improves lives. I think there's sort of an initial point that I just want to land, and I know there's a lot of people here from local authorities, but there are also others who are joining from other sectors, and that's that the factors that drive our health, these building blocks, sit largely outside of the health and care system. And within local government, we have the opportunity and the privilege to be able to influence these factors directly for the residents and the communities in the places where we work and often live. And so it makes the role of local authorities critical in both understanding, but also developing and designing services and systems and programs that can best influence these broader building blocks to create healthier places and to tackle underlying inequalities. Essential to this is inevitably the data infrastructure that we have put in place to support our use of that data as well, and then the skills and resources that we have at our disposal within those organisations. I think before I get into the detail of a few examples that I want to share with you today, it's worth also noting the context within which local authorities are doing this work. It's no surprise to anyone that the financial circumstances have been challenging. This is looking at spending power of local authorities over the last decade. When you look at the central government grant allocations, it's a far worse picture. This obviously incorporates here revenue raising opportunities for local authorities such as council tax. And you can see that overall there's a reduction in spending power for the majority of local authorities. And furthermore, underneath this chart, there sits an inequalities angle whereby that reduction in spending power has been most keenly felt by local authorities that are serving some of the more deprived communities and populations in England. Within the overall financial challenges that local authorities are facing, the public health grant specifically has seen a series of real terms cuts over the past decade. Now, in the last year, there's a very welcome above inflation increase, and then the previous year to that, there was also an increase to support agenda for change payments for NHS commission services. But even despite those, it's worth noting that there's still around a 25% reduction in the value of the grant per person over the past decade. And so as a consequence, local authorities are often being asked to do more with less. So this is the public health picture, but those of you who are working in the sector will understand the pressures being felt by children's services, special educational needs and disabilities, adult services, and elsewhere. And the consequence of that rising demand, often increasing costs, and the financial constraints is being keenly felt and making the news in many circumstances, despite some of the ongoing changes to central government budget allocations. This underlying context, for me, makes the value of using a data-led approach to understanding how we can prevent disease, how we can support service provision, and how we can understand the most effective and efficient ways to manage population health needs becomes all the more important. And that can be done both through research, but also through things like service evaluations and service design, and the needs assessments of how of what types of challenges we want to engage with, all the more important. So this is Oxfordshire. This is what we call our snake that sits underneath our joint strategic needs assessment. And I think it's just a really nice illustrative way of showing the different data points that we have relevant to the well-being of people in the county across the entire life course. And this takes us from pre-birth through to end of life. And some of these indicators are very explicitly health related. So, for example, they might be deaths from cancer or diagnoses of mental health conditions, but a lot of them also relate to more distal factors, some very public health oriented, so things like prevalence of overweight and obesity, others more distal to that, so things like being in employment or unemployed, living in fuel poverty. And it's this raft of data that I think illustrates the kind of superpowers that local authorities have to support a data-led approach to prevention. So I talk to colleagues, academic colleagues, but also to political colleagues in Oxfordshire a lot about how at times of resource constraint it becomes all the more important to engage in research, to think about how to most effectively and efficiently use those limited resources. And the reason why we're such a, I think, an important part of the kind of research and insight-led ecosystem is firstly because of all the data assets that we have. So that's across not just adults and children's services, but also things like community safety, domestic violence, planning, licensing, transport, air quality, and more besides. Secondly, I've touched upon it already, but the skills and resources that we have in local government. There is obviously a data and intelligence function, often in public health teams or more centrally. But beyond that, there are professional skills in places like planning and licensing and environmental health, where the opportunity to interpret and interrogate different data, both qualitative and quantitative, is really important for being able to understand what's driving health needs and opportunities to address them. The third area, which I think is super critical to emphasise, is our community relationships. So local authorities, by the nature of the statutory services they have to provide, but also because of the long-standing sort of anchor institution function that they have, the fact they're grounded in place and have been there historically over multiple generations, means that they've built up a lot of very trusted and close relationships with some of the most vulnerable and marginalised communities in their local area. And through those relationships, there becomes an opportunity to develop the qualitative work, to understand what are the local assets and opportunities to do things differently, as well as to broker relationships between research organisations and others who might want to work with and partner with community organisations. And that's a two-way conversation. So I'll talk about our community research network shortly, but through that network, we also try and provide space where community-led opportunities for research and learning can be taken forward in partnership with relevant experts from a methodological or academic perspective. And the final point, obviously, is local authorities do have an awful lot of policy levers and can deliver real tangible change at place. So there is a chance to complete that cycle of that policy cycle of being able to learn from insight, do something differently, see a policy change and impact on the ground, learn and do again. So some examples from Oxfordshire. This is our joint strategic needs assessment and our data hub. So we've now got a fully kind of digital version of this, which has been put in place over the last year. It gives the opportunity for residents, for community organisations, for local businesses, for partners in the NHS, social care and in academic institutions to be able to interrogate this kind of stuff and to see what's going on in the county and see what's changed over time. We do this at the with using routine data and locally collected data for the county, and you can then obviously scan down into more local areas as you go. But we've also, in some of our most deprived wards, some of our most deprived communities, gone into this in more detail, where we've created these things that we call community insight profiles. All of these are also available online. The reason why we led on these was to take some of the sort of quantitative indicators of where there seems to be a greater deprivation and greater potential health or other needs in a particular place, and then pair that up with the qualitative insight where we worked very closely with local partners to support a real kind of asset based approach to how we can support these communities to develop moving forward. So there are an awful lot of qualitative interviews that took place with community groups and local leaders, and then following that, and following the insights that this qualitative work led to, we then funded community health development officers in those local places who those were often drawn from local community groups, so local people being employed to take forward the kind of opportunities and develop the kind of assets that were identified through this community insight profile work. And I think it's a really nice example of how we've been able to pair some of the quantitative insight along with qualitative data to support local places to do things differently. And as those of you who, particularly those in public health, will be all too aware that when you take an asset-based approach in partnership with a local place, you're far more likely, fingers crossed, to have sustainable change at that place because of that shared ownership of what matters and how you're going to address that between, in our case, the local authorities, so the people who might be funding some of the policy changes or delivering some of the services, as well as the local community. Our community insight profiles were initially decided based on where there are areas of the greatest deprivation within Oxfordshire, and we're a relatively affluent county, but we do have some real pockets of significant deprivation. And so we were particularly interested in the update to the index of multiple deprivation that came out, I think, just a couple of weeks ago, updating the 2019 scores to the 2025 scores. And I'm just going to illustrate some of this and talk about its potential use before going on to one or two specific research examples. So this is an example of our tartan rug for the data that came out a couple of weeks ago. These are some of our lower super output areas. I'm not expecting you to look at the detail, but on the left-hand column, these codes and numbers are our lower super output areas. That's basically populations of around, what, 3,000 to 5,000, I think it is. Maybe it's a little bit less. These are in Oxford City, so one part of the county. And then the columns where you see the colours, the tartan rug element, are the different domains in the index of multiple deprivation. And even at a glance, you can see how some of the domains are far greener than others. And so within these LSOAs particularly, you've got a very green kind of space in the domain around the living environment. That means that these places are in the much higher decile compared to the rest of the country, whereas there's a lot of red in areas, for example, around some of these pockets around things like crime or education. And also one of the examples is income affecting older people. And so this provides an initial way into a conversation with the communities and people in these places, as well as with our politicians and other relevant organisations, to begin to unpick what might be underlying these data. We can also look at how things have changed over time. And this bottom right-hand corner is the same community as the profile I showed you in the previous slide. So this is the LEAs, and these are the LSOAs, the lower super output areas that make up that community, make up the LEAs. And this shows us, firstly, their IMD score in 2025 of those different LSOAs on the left-hand column, and then how it's changed since the previous IMD score in 2019. And what's really interesting to note is that we've got significant improvements across many of those places on things like living environment, an area that we've done an awful lot of work in over the last 5 years, whereas there's been areas where things have gone worse or not changed in things like crime and education. And that gives us another really lovely signal to be able to then go and continue the conversations with people and community organisations living in those places about how we can maybe understand what's underlying these data, what communities are feeling on a day-to-day basis, and where there may be further opportunities to do things differently and support. And together this underlies our broader approach to research in the council. So we've just launched our research strategy at Oxfordshire County Council, and it's kind of underpinned by this sort of tripartite way of thinking about what matters to residents and communities, what we are able to influence ourselves, that's the council priorities and policy relevance, is stuff that we can change. And then finally, what's the evidence gap and the academic feasibility of addressing some of that. And together we think that that gives us hopefully policy relevant research that can deliver change that matters to people in the county. So a couple of examples. I've gone on, I'm going to go, the examples are very sort of data heavy in the theme of today, and hopefully valuable, and I'm going to talk a little bit about NIHR and then I'll wrap up. So this, I think, is just a really nice example. It's not from public health, it's from social care, but this is a piece of work we did a couple of years back, and we haven't yet submitted it for publication, but the papers, the first draft of the paper has just been written up, done in partnership with Zhao, Andrew and David at the University of Oxford, where we worked with them to share and analyse our social care records, adult social care records. And so they're able to look at 28,000 anonymised care records from the county, and then using a machine learning approach, so training a machine learning algorithm and then using a prediction element to it, were able to look at potential predictors of individuals within our social care records having a care plan put in place, having a hospital admission, and then also predictors of mortality. And they were able to look across a vast number of variables to see what potential variables might give us an early signal of an individual subsequently needing a care plan put in place, likely to or not have one or more hospital admissions, and then also what might be precursors to mortality. And it's this is a very data heavy led approach that will give us hopefully, and as I say, the results that's only recently been reported, support us in thinking about prevention opportunities for early intervention in our social care team to support people who are either at risk of needing to go into more intensive social care service provision, whether that's residential service provision or more intensive domiciliary care, and also from a broader kind of system prevention management perspective, trying to reduce demand on hospital admissions as well, and ultimately delay mortality as well. And so this sort of data-led approach is already affecting how we are looking to particular places to shift our preventative work within the social care team, and it's being done in partnership, as I say, in public health. The next example is from our NIHR portfolio. So the National, for those who aren't aware, the National Institute for Health and Care Research has a public health research programme. It also funds a real range of public health research activity through a School of Public Health Research, as well as through these things called health determinants research collaborations. These are local authorities. There are 30 of them in the country that have been given 5 million over 5 years to support capacity and capabilities in research. We also fund something called a FIRST scheme, PHIRST, which helps local authority evaluations. So local authorities are partnered with academic teams, and they provide a robust academic independent evaluation of a particular service that's novel in a particular place. And collectively, there is this broader NIHR ambition to really think about strengthening our opportunities to understand the drivers, those wider structural factors that drive poor health and inequalities, and what we can do to address them. Most of our research in NIHR is focused on evaluating or understanding interventions that are either already in place or new interventions that are coming in place, either through natural experiments. That's basically taking a policy that's been put in place and seeing what happens for that policy, or through more formal experimental design. So that might be through a trial or something else similar. A couple of studies that I'm going to flag here, I think, are really nice illustrative pieces about how we want to support more coherent data use and integration in local authorities. This is the Connected Bradford work, which was funded a few years back, and this was explicitly looking about how we can support and accelerate a more integrated data set and way of data partnership working between predominantly health data and non-health data. So that's the transport data, it might be the air quality data, or other data sets that local authorities have. Education, another good example, that can then underpin broader research projects. And so this team then went on to do this really important evaluation of the Bradford Clean Air Plan, and it showed through linked data sets not only that over time there was a decline in air quality, there was an improvement in air quality, a decline in pollutants following the implementation of the clean air zone, but also then able to link this to changes in chronic disease presentation, to secondary care, and to broader NHS service demand. So a really neat example of the power of joining up those data, and also the opportunities that NIHR might be able to present to support that type of research. A second example, which I quite like, which is rather than being a specific local authority, this is now looking across the whole of England and Wales, where routine data from police and crime data, as well as care NHS data, were used to try and understand the effect of reduced street lighting policies across local authorities in England and Wales on things like crime and road traffic accidents. And this is one of the papers that came out of this research, and it showed that, broadly speaking, different reductions in street lighting policies across local authorities in England and Wales, whether it's dimming or part-time reductions or changes to the type of light, made relatively little difference, and often reduced incidents of particular types of crime, for example, as this figure is illustrating. So again, another really neat way of using data to understand the impact of particular policy designs that can inform and shape public health policy more broadly moving forward. So my final slide, I'm just going to do a plug for the public health research programme, and also for public health research more broadly across NIHR. There's a link at the top there, and that page, so if you just type in NIHR public health into Google, it will help you there as well, brings up all those different bits of what NIHR does in public health. And one of the key things for those who are interested in research is something called the Specialist Centre for Public Health, and there's a link here on this final slide, and the whole purpose of that NIHR Specialist Centre for Public Health is to support organisations outside of clinical settings to do research on those wider factors that drive health and inequalities. So that's everything from think about how you might develop your research question, what method support you might need, also things like public involvement. They'll do support for grant writing, for mock interviews, and there's also some post-award support. There's now pilots to support with things like ethics and others besides. So it's a really fabulous kind of one-stop shop for those who are interested in developing more research in their local authorities if you're not aware of it already. So strongly encourage you to be aware of that, and you can look it up and put in requests there directly. And then just to emphasize these other final 2 points of mine is that firstly, like, local government has got these phenomenal assets when it comes to data, as well as community relationships and its people. And that community involvement is really valuable and I think essential to how you pair together both the quantitative data along with the qualitative work that will allow you to get under the surface of why, how and who is most impacted by those quantitative insights. So I'll leave it there, Mark, and thank you very much everyone for listening.
Thank you ever so much for that, Adam. And it was particularly interesting to hear about streetlights as well, and how the information on public health links into that. It just shows how valuable the work we do is on setting policy for everyday things there. Particularly interesting as well about putting all this into reality and the pressures that councils are facing. Adam, we do have a lot of questions coming in too, if you don't mind sticking around until the end, just to help out with questions and answers. And for everyone in the audience, we will share any links around along with the slides. Our next presenters today, though, join us from Suffolk County Council, and they have been doing some remarkable work. They have worked on initiatives across Suffolk, including partnerships with the ICB. They've developed in-house R packages, and today, though, they are here to share with us their work they've done on suicide prevention in Ipswich by using data-driven insights. So please give a huge welcome to Kathryn and Rebecca. Over to you.
Thanks so much, Mark. All right, I'll just share my slides. So good afternoon, everybody, and thanks so much for inviting us along today. My name is Becky Allen. I'm Head of Public Health Analytics at Suffolk County Council, and I'm joined today by my colleague Kathryn. Kathryn, would you like to introduce yourself?
Good afternoon, I'm Kathryn Loxton and I'm a Senior Public Health Data Analyst with Suffolk County Council.
Thanks. So we've come along today, as Mark has said, just to share some details about a recent suicide prevention initiative in Ipswich that's used linked data to take a really targeted approach to delivery. So we'll be talking a bit about the project itself, why it was a priority area of work for us, and then Kathryn will take us through the more interesting bit, the analytical process which underpinned the project, and we'll show you some of the snippets from the SQL and the R code that was used to interrogate the data. So I'd just like to start with a wellbeing warning, really, just to highlight that the content within the presentation might be emotionally challenging for some people, and the slides do contain information about death by suicide and serious mental health issues. So we just encourage people to take any action that you might need to take. I think you can dial out of the webinar if you need to at any point and dial back in again. So I'll just begin with what I think is the quite shocking statistic that suicide is the leading cause of death for men under 50 in England. And in England and Wales in 2024, there are over 6,000 suicides registered. 3/4 of those deaths were in men, and the highest of those rates were in men of middle age. And really, I think, as you can see from the chart at the bottom of the slide, over the last 25 years, suicide rates haven't really shown any improvement in England, and Suffolk very much mirrors those national trends. In addition to being male, the evidence base is really clear on factors which put individuals at higher risk of death by suicide and poor mental health, and they include factors like physical illness, social isolation and loneliness, substance misuse, harmful gambling, financial difficulty, deprivation, domestic abuse, contact with the criminal justice system. And indeed, the government's suicide prevention strategy really emphasises the need for us to take note of those particular risk factors and to provide tailored, targeted support to groups who might be at higher risk. The strategy highlights the importance of data sharing at local and national level with the aim of preventing suicide deaths, and directs systems like ours to engage with services that men commonly come into contact with in order to provide appropriate support and signposting for suicide prevention and mental health services. And engaging with those services and venues that men frequently come into contact with is the key premise of this suicide prevention project that we're here to talk about today. So this project was initiated in Ipswich, the county town of Suffolk, last year, and it was developed collaboratively by the Ipswich Integrated Neighbourhood Team, which has representatives from Suffolk County Council, Suffolk and North East Essex ICB, and a range of other health and care partners. The project team worked really closely with the 12th Man campaign. And if you haven't heard of 12th Man, it's a grassroots mental health organisation, and it's aimed at equipping individuals, particularly men, with knowledge, skills and confidence to support mental well-being in their own communities. And incredibly well timed for the webinar today was the brand new Men's Mental Health Strategy for England, which launched yesterday, coinciding with International Men's Day. And within that strategy, community-based approaches which reduce stigma around men's mental health and tackle known risk factors are really at the very core of the approach to improving men's physical and men's mental health outcomes. A key premise of the project was to work with Ipswich businesses which have frequent engagement with men, and that included tattooists, barbers, gyms, sports clubs, taxi companies, a real variety of business and organisations. And 12th Man were commissioned to deliver mental health awareness training to those businesses and to offer broader sessions to staff working in those sectors with the aim of improving confidence and ability to have open and frank conversations without any stigma around mental health, and to improve emotional literacy, and also just to really encourage peer support among men. Now, there are many hundreds of businesses and services, organisations across Ipswich and the wider Suffolk area that meet this kind of criteria. And I think, as Adam touched on earlier, time and resources are not infinite. And so for this reason, we took a real data-driven approach to prioritise specific areas of Ipswich or particular neighbourhoods to deliver these training initiatives first. So really taking a targeted approach to engage early in areas that potentially had the highest need. We're very fortunate as part of Suffolk and North East Essex integrated care system that we've got a large linked population health data set, which brings together data from across the health and care system at person level. And that includes data from primary care, so every GP diagnosis, every appointment, data from hospitals, inpatients, outpatients, A&E visits, ambulance call-outs, adult social care contacts, mental health inpatient stays and outpatient, community health services, and wider determinants data on things like fuel poverty and deprivation, for instance. And the linked data set is held in a secure data environment where analysts from across our system can access it and interrogate it to answer questions in ways that we've never been able to answer questions before. And we've also got Pathfinder for use by the wider system, which is provided to us by our partners Optum and sits on top of the linked data. And that gives us really quick access to population health intelligence via a series of dashboards. Having access to this data set and to these tools means that we're able to segment our population, for example, by age and by sex really quickly, and to stratify the population in terms of risk, and to use that to inform proactive interventions such as this particular project. So now I'm just going to hand over to Kathryn, who is the analyst that did all the hard work on this and used the linked data set to really inform the direction of the project. She's going to talk a little bit now about how she was able to identify a series of indicators which align to those known risk factors for suicide and poor mental health, and prioritise key neighbourhoods as part of the project delivery.
Thank you, Becky. So there is no single indicator that fully captures the risks associated with suicide and poor mental health. Instead, we draw on a broad range of indicators that reflect the known risk factors. So for this project, we combined evidence from the literature as well as we got expert input from Suffolk County Council's mental health lead. As Becky has already mentioned, we focused on sort of 6 key domains, and that is the physical illness, where we were able to capture indicators from our GP records, such as chronic pain, where we could identify this through the usage of people who were taking chronic pain medication, as well as various health conditions. For mental health, we could look at recorded instances of anxiety, suicidal ideation, and attempted suicide. Though it's important to note that stigma often prevents disclosure. And so for our data, we can only actually capture what is actually recorded. And it's something for this particular topic we were well aware of. Other areas was for our social isolation. Looking at community care data set, we were able to get social vulnerability, and we were also able to pull national data on people living alone. For financial difficulty and economic adversity, we were able to use these wider determinants of health captured from the latest census data, so including the IMD, fuel poverty, and homelessness data. For alcohol and substance misuse, this was captured through our GP records. However, we will always be constrained by the limitations set by our data. So we did not have access to information on domestic abuse, harmful gambling, or contact with the criminal justice system. However, there is scope with linked data to incorporate these kinds of indicators in the future. So, I'll go through the whole process of what we did for this project before we dive into the code. Ultimately, we identified the prevalence. So looking at that top left box, we identified the prevalence of each of our risk factors by our geography area. For those that are familiar, we used our lower super output area codes, so that's LSOA codes, that divide up our area into smaller neighborhoods. Next, for each risk factor, we ranked the areas. A ranking of 1 meant a higher prevalence, and a higher number indicated a lower prevalence. So, for example, because this is a little confusing, LSOAs were prevalence of with a high suicide attempt, that was given a number of 1, and areas with no recorded suicide attempts was given a higher number. Ultimately, though, you can decide the direction of these kinds of numbers. To me, when I was doing this, a 1 equaling a highest or a worst just made sense to me. Then, for each LSOA, we added up the ranking values to get an overall sum. And this overall sum score reflected LSOAs with the greatest number of risk factors for the suicide and poor mental health. Once we had these scores, I added an additional step just to make the mapping side easier, and I ranked those overall scores so that the highest combined risk was giving a lower number. And finally, this is what we used to build that heat map. And here is a production of what we did for the whole of Suffolk rather than just for Ipswich, where we had the highest prevalence of these risk factors in red and areas with the lowest risk factor in green. So in short, what we did was we calculated the prevalence, rank each of those factors, sum those rankings, rank the totals, and then visualize the data. So let's have a look at the code. So we used a combination of R as well as SQL for our project. SQL is visually easier for me to read, and that's just my personal choice to pull the data from our warehouse. But we also had R, and I used that to do the cleaning, transforming the data, and creating most of our visuals. Just a starting point, we actually had an in-house R package built, and this was developed by our SNE, so that's Suffolk North East Essex ICB Intelligence Function colleagues. And this allowed us to not only connect to our database, but it also gives us some custom functions as well. It is a luxury item, and I would recommend any council or any area that uses R, and if they're doing any processes which are repetitive, to look into creating your own package. Additionally, here are some of the other packages we used for this project. I will say TidyLog is one of my favorites. It just helps when you're doing joins, just to see how those joins looked. Okay, so this is what it looks like to have SQL within your R to pull data from your data warehouse. So like you are pulling data in SQL, this chunk is just the list of indicators using that select statement where we are interested and where we also apply our filters. For the filters for this project, we were only interested in men over the age of 16 and over. And we wanted to look at more specifically those men living within the community, so those that would have the potential to access our targeted community businesses. So we excluded those who were in care homes, and this care home indicator included those living in mental health support facilities. Of note, it is important to get into the habit of pulling data that you need. You want to not pull everything possible, because this is only a single year's worth of data. It's a relatively small chunk of code and it will run quickly. But if you pull everything in, you're going to find that your code takes a really long time to run, but also you could be choking up the connection for other users. For this particular example, you'll see the first chunk of that is us creating a list where we've got that SQL code, and then we use the DBI package in R to pull that data. And this one is what it uses first to connect using that con function. And then we have the statement which goes back to the list that we created of that SQL code. There is more than one way to pull a query from your warehouse. Those that are more familiar with R, you can use the dplyr package and use the function collect. And again, it'd be the same similar process you could use, just absolutely up to your preference. So the code on the left is our main data. It shows all those indicators. Very fortunate that the way that the data is already in the data set, it's 0 or a 1 for each of our indicators, making it indicate easier for us to identify who has and hasn't got that condition. And we will use this to create the prevalence. The code on the right is where we wanted to use a case when statement to create a single indicator that captured if any of those health conditions that we were looking at, somebody had any one of them, we just give it a 1 function. So I chose to run these codes as 2 separate queries. You could do it in one large chunk, but when we were doing this project, I was adding additional indicators into that second query. And it is a lot easier to run a small chunk of code multiple times than try and rerun a massive chunk. So other bits that we were very fortunate at that time, the latest census data at LSOA level for overcrowding, households living alone, and no central heating were made available and ahead of what we had in our lake data. So I was able to pull them in sooner and take advantage of not only the fuller and rich data, but more up to date. And it was really useful to have that at that time. It's often the messiest part of anyone's code, including my own, and that's the cleaning. So before you can even start doing any of your ranking or your mapping, you need to spend the time cleaning your data. It helps you with consistency, such as renaming columns so your joins are neat and make sense. You also how you're transforming the data, going back and forwards between maybe a wide and a long format. Because we were calculating the tables by LSOA, we also needed to aggregate our row level data up to that LSOA level and to calculate this prevalence. For our project, we just used crude rates per 1,000 population. But this step is so important. Without clean, well-structured data, everything else that follows, whether that's the ranking, the mapping, interpretation, will quickly fall apart. So let's have a look at some of the prettier visuals. So this chunk of code, we used a wide format to create the table that's color coded, where the highest prevalence shows up as yellow and the lowest prevalence in dark blue. But it is also important to remember that not all of our indicators are going from that same direction. We have IMD, where a high number in IMD would actually represent a least deprived area. So you will note in the next chunk of code, I'll show you where I take this into account. So again, another shout out for cleaning and labeling your code, also commenting your code so you remember 3 years later what it was that you were doing. I will say that R is fantastic at giving you options for different colors that you can use. They also have an accessible color palette. We didn't use that for this one, but it would be helpful for those with color blindness. This is the chunk of code where we took those rankings and we from our prevalence. So the first step, and I'll just get my pointer, is that we grouped. First step is that we just pulled out that IMD decile in there and we grouped by our indicators. Then we arranged going from largest prevalence to the smallest prevalence. And to add a ranking very cheaply, we used row number. And this was grouped by the indicators because we wanted to see within that indicator which one was the highest. So now we're having taken our decile out, we're adding that back in because we didn't need to order our decile. We wanted it to remain 1 to 10 in this case. So next step that we did is that if you look over here, we've got all those rankings at the bottom, and just to make it clearer, you can see that for this particular LSOA, a physical condition was given a 1. That meant they had the highest prevalence for those with a physical condition, or a mental health, social vulnerability, attempted suicide, or suicide ideation. So you kind of get the idea. The next bit where we want to create the column that allows us to have the overall sum, so 282, is where we've just summed up all of these values. And by doing that, it's going to show us where we want to put that focus. You know, it gives us this overall connection. We're making a single indicator out of all these risk factors. But 282 doesn't quite make sense. So this is where I applied that additional step and I ranked our overall sums, and it makes it a little bit easier to then see. We're going to export this, and there you can see actually for this one, for the overall rank, I did actually use a dense rank function because unlike a row number, dense ranking, I wanted it to take into account ties where you'd get the same value coming up, and we really wanted to capture those as the same. Giving it a row number, they would have been just numbered. That wouldn't take that into account. So that's how we got our data and those values that we could then turn into a legend and build into our heat map. Now for us, we used ArcGIS. It is completely up to you. You can import the shapefile into R and produce these maps. However, at the time we were doing this project, we had our particular member who was advanced in using ArcGIS to create these maps that we could share the link with our stakeholders, and it was the most pragmatic choice. And I think it's important to make a note that it's okay to use different tools for what you need, choosing the most pragmatic option. It depends on what skills are available, what tools are available. And if I were to run this project again, we would probably do the entirety of it within R. So there is our total map and the final output that we were able to share. So I'm going to hand it back to Becky, and I'm going to allow her to go through what project outcomes and impacts were.
Thank you. So I'll keep this quick because I think we're quite tight for time, but just to add in a bit, as Catherine says, a bit about what happened next. So the heat map was used to prioritise areas across Ipswich for training and engagement. Over 100 different venues, clubs, businesses were engaged with. Detailed training was provided to 37 leaders across these community venues, which led to increased knowledge of mental health in leaders and boosted their confidence as part of the follow-up evaluation. Next slide, please, Catherine. And just to finish with some feedback, now I won't read all of these out, but I think the one on the left really sums it up for me. This was a quote from one of the sports club leaders who told us that it certainly gave the confidence to be more aware and recognise the symptoms and signals from someone suffering mental health issues, and more importantly, offer help or advice where professional help is available. So I think that's it from us. Thank you very much to everybody for listening. We've put some more links to some of the population health management work that we do across Suffolk and North East Essex, a link to 12th Man, and also our contact details if you'd like to get in touch. Thank you.
Thank you so much both for that presentation. It was really amazing to hear how this work made real, accountable benefits for people, which I'm sure everyone on this call today are really grateful for here, especially when thinking around about the use cases. Particularly fascinating about the code as well. There's a lot of tips and tricks in there which I didn't even think of. So absolutely, thank you so much. We do have a lot of questions coming in, so are we okay at the end to do some questions and answers? Brilliant, thanks ever so much. Our final presenter today, though, joins us jointly from the London Borough of Lambeth and the Royal London NHS Foundation Trust. They bring with them today a Masters in Health Data Science and are sharing with us their work on modelling survival outcomes against NHS health checks, which is truly fascinating. So please give a huge welcome to Jasjot. Over to you.
Hi, thank you, Mark. Hi, everyone. I hope you can hear me okay and see my slides okay. So yeah, I'm Jasjot. I'm a public health registrar. I was doing some work with the Lambeth Council, which is what this project that I'll be presenting is from. So again, it will be insight into R, so how we used R to model survival outcomes among individuals who have and have not had NHS health checks. So what is the NHS health check? It's a national risk assessment and awareness programme that's designed for 40 to 74-year-olds living in England who do not have existing vascular or cardiovascular disease and are not being treated for certain risk factors. So that essentially means it's aiming to prevent conditions like stroke, diabetes, heart disease, kidney disease, as well as other vascular and cardiovascular diseases. So this map is from a national publication of the health checks uptake between 2015 and 2020. So it's a 5-yearly recall programme. So we would hope for a 5-yearly uptake check to be over sort of 70%. So when we zoom into London in this box, you can see that slither of sort of light purple in the inner London boroughs, and that is Lambeth. So that's where we are. So it really highlights that Lambeth's 5-yearly health check uptake is the lowest in the inner city boroughs of London. So that's where we are. And in terms of the sort of background to NHS health checks, they've been mandated to be delivered by local authorities since 2009. Although they're delivered by healthcare professionals and they're commissioned by local authority. But there's been uncertainty around the long-term benefits. Recently, there was a published journal article using a data set called the UK Biobank, which is quite a big, impressive data set, which highlighted that it's associated with reduced organ disease. So that's a positive finding. But historically, we use randomized controlled trials to look at the impact of interventions. And a Cochrane review in 2009 of 11 randomized controlled trials showed uncertainty in health checks in general, and saying that they might not lead to benefits. So in the meantime, things have been sort of ramping up locally. Lambeth was awarded a pilot to roll out health checks into workplaces. NHS health checks are part of our Vital 5 in our health and care plan in the council. And we also received an award to pilot digital health checks as well within the borough. So we wanted to know if NHS health checks are associated with improved survival, so long-term outcomes in Lambeth's particular population. So I'll be going through this sort of banner on the left-hand side. And just to note that this was a joint sort of health data science project, along with a project with the public health team at the council. So we're fortunate to utilise several data science approaches, which I'll talk through. And I've also sort of highlighted, again, the sort of key packages that are used, so you might find them useful as well. Yeah, so this was essentially to fill a gap in research that was looking at long-term effectiveness in an ethnically diverse population. So I didn't mention before, but that UK Biobank cohort that was used in the previous analysis is predominantly a white cohort of 96%, whereas in Lambeth we have around 40% non-white population. And we wanted to look over the full course of the NHS health check programme since 2009. And we wanted to use real-world data so that it was representative. So we'll start off with the data set. So we use Lambeth DataNet, which is a GP electronic health record data. So this extraction covered the period between 2005, so before NHS health checks were implemented, up to 2023. It covers over 1 million unique individuals. And this comprises of all the registered GP population that have been in Lambeth. So we're really lucky to use this data set. And in terms of software, everything was done in R. So we chose R because we wanted sort of reproducible and open source code. It handles our large data set relatively fast, but as you heard in the previous talk, it can get clogged up, and I'll talk about some of the limitations a bit later. And it meant we could create an end-to-end pipeline of our analysis. So from the cleaning to the statistics to the visualization, we could do it in sort of a relatively simple pipeline that meant it could be repeated on other data sets. So how did we define the cohort from our data set? We had an inclusion and an exclusion criteria. The inclusion criteria was made up of those who were eligible for a health check, so the criteria of 40 to 74 without pre-existing cardiovascular disease. So overall, we ended up analysing over 150,000 individuals. And we excluded people, which I'll talk about a bit more, who had poor data quality or completeness. So I'll tell you how we handled that. Or an inadequate look-back period. So it was important for us to have at least 1 year of data before they entered our study. And this was just to ensure that it gave them time for their records to be up to date. So for a lot of this, like you can see in the bottom right-hand corner, the R package that I found the most useful was Tidyverse, which has already been brought up in the last talk. So this is really great for handling and managing data, and it's got sort of multiple subsections to it that are particularly useful, including dplyr. So how did we handle missing data? So we wanted to use statistical approaches to ensure that anything we did with missing data wouldn't impact our results. So firstly, we wanted to sort of look at the frequency of missing data and the combinations of different variables with missing data. And this is a really nice package called GG Upset. It's called that because this is called an upset graph. I'm not quite sure why it's called an upset graph, actually. I might have to look into that. But it made me very happy because I could see quite clearly what was the most frequent missing variable. As you can see, that's alcohol. but also highlights the combinations of missingness. So alcohol and BMI is the second most frequent combination, and then language was the third most frequent. So this really helped us decide which variables we felt were essential for analysis, which ones were unusable, and which ones we could potentially impute. We also looked at missingness distributions between over time and between our health check and non-health check group as well. So essentially, we ended up deciding on 3 data sets. So one main analysis data set, which we used mode imputation. So this means we imputed missing data with the most sort of common category, and so these were categorical variables. We also then produced a complete case analysis data set. So that means that any missing data, any rows with missing data were removed. And then finally, we used multiple imputation by chained equations, which is another method that I'll go into the next slide, as a third sort of data set to be used in sensitivity analysis. So we use the R package. Oh, sorry, my screen went funny. We use the R package called MICE, which is multiple imputation by chained equations. And what this means you can do is you can take an incomplete data set, and so the pink dots sort of highlight missing variables, and because they're missing, we don't know what they are. So there's a sort of a range of variables or a range that they might sit between. So because of that uncertainty, instead of just imputing one variable, we can create multiple data sets within that range to account for uncertainty. We produced 5, but you can produce more. And this was mainly because our data set was so big and due to computational limits that you can sort of really run into stuff taking quite a while to run. So 5 was sort of optimal for us. Once you have your 5 imputed data sets, which all have different imputed numbers to account for the variability, you can analyze each data set, and then you pull the results. And there's a set of rules called Rubin's rules, which is all under this MICE package, to sort of pull that into your final outcome. So we also wanted to look at differences in baseline characteristics between those who had and hadn't had a health check. So we used statistical testing and regression to understand if these differences were significant, and we found that people who had a health check were more likely to have a family history of coronary heart disease. They're more likely to have a higher BMI, more likely to be from a non-white background, and more likely to be females. We also found that they were younger, less likely to drink excessively, less likely to be from a deprived area, and at about the same rate of smoking as those who did attend a health check. So this is quite important, and I'll talk about it a bit more later, because we wanted to understand if those attending a health check, are they generally a healthier population, or are they sort of similar to the rest of the population? And this sort of shows a bit of a mixed picture. So again, we did some geospatial mapping as well to identify patterns geographically, but also over time. And we used the R package called SF, which is like shapefile, to bring in and read a shapefile that's sort of related to Lambeth, and then on top of that map the uptake of NHS health checks, and we segmented it over time. So this shows the 5-yearly uptake in Lambeth, and you can see that between 2009 and 2013, the uptake seems sort of up to about 25% in most places, and this sort of has gone gradually down. And just to highlight that the most recent uptake is sort of during the COVID pandemic as well. So that was a time where NHS health checks were deprioritised, so that would have impacted this finding. We then compared that map as well, just to, you can compare it to deprivation map to reveal more insights. And for example, this just highlights how that remaining higher uptake area during the COVID pandemic potentially is sort of related to an area of lower deprivation. So it's just sort of interesting to see. So for our longitudinal survival analysis, we used a Cox proportional hazards model and a particular type with a time-varying exposure, which I'll explain. So the package for this was called Survival, and that has most of what you need in there. So this sort of study design diagram shows 3 potential participants over the period of time of the study period, which is marked by the red lines, and the black dot is the start of the follow-up. So that would be when they became eligible for the health check, because that was our inclusion criteria. And everybody starts unexposed, so they haven't had a health check. So that's what the grey line indicates. And the time-varying exposure element comes from the fact that if and when they have a health check, they then become, that time contributes to the exposed time. So that's indicated by that sort of bluey purple line. And then we end follow-up either at an event, which we were using death, administrative censoring, which is sort of the end of the study period, which for us was 2023, or loss to follow-up. So that's indicated by that red bar. So in order to account for confounding factors in our analysis, we used a weighting method, and this was in the Weight It package. And so the weighting method basically takes, is similar to matching, but instead of sort of only using participants that you can find a match for, weighting means you can use all of the participants and just apply a weight to how much they contribute to your final analysis. So the way that works is you use the probability of receiving a health check given their certain characteristics. And then you take the inverse of this, and that is your weight that you can apply at the analysis stage. And you can check if the weighting has balanced your data set, because ultimately we want the data sets to, so we want the health check group and the non-health check group to have similar baseline characteristics so that we can compare them. And so by checking their propensity score distribution, after we calculate the propensity score, this is before we weight, you can see that the health check group and the non-health check group have quite different distributions. And then after weighting, you can see these distributions overlap much, much better. So that's a really positive finding of the weighting being successful. We can also check the weighting success by looking within each characteristic. And so the red dots represent basically the difference between the health check and the non-health check group within these characteristics. So I don't know if they're coming up because they're quite small, but we've got age, BMI, ethnicity, current smoker, PCN and IMD. And you can see that the red dots, some of them go beyond the red dotted line. And that means the difference is too big. So it's not a balanced data set. And that's before weighting. And then the blue triangles are the difference between health check and no health check group after weighting. And you can see that these line up really nicely along 0, which means there's minimal to no difference. So that's really positive to show that we've not only balanced the data set as a whole, but within each characteristic, the data set is balanced too. So we really wanted to make sure that our results were sensitive to missing this. We also wanted to make sure that after we added these weights, is this new weighted data set still representative of Lambeth's population? And we also wanted to check if once we do our main analysis, is the finding robust to the COVID pandemic period as well? So on top of our main analysis, we replicated the analysis on the 5 imputed mice data set, the complete case data set, and a pre-COVID data set. And then we also validated the final weighted data set against Lambeth's actual registered and eligible population to make sure it was still representative. And just to note that this was much easier, having done a sort of a reproducible end-to-end pipeline in R. It meant that we had to make minimal changes to the initial shaping of the cohort, and then we could run the end-to-end pipeline of the main analysis essentially on different data sets. So that was really positive. So what did we find? We found that NHS health checks were associated with a third decreased risk of all-cause mortality. So that's a reassuring finding. And you can see we used ggplot to plot this graph, so I forgot to put that in the corner. But this is an estimated survival curve and highlights that in the red line is significantly different from the blue, which highlights that if without a health check after 15 years, you have a relatively low survival probability compared to those who had a health check. So what were the strengths? We used robust data science approaches, including balancing our data set, testing the sensitivity to missingness and COVID, and validating the data set against Lambeth's population. We had a long follow-up time, real-world representative data, and we can also repeat this relatively easily on other data sets in other areas. So as I mentioned, there are limitations, and one is the sort of residual confounding. So that's confounding that we may not have been able to take into account. And one of these is the healthy attender bias, which is why we wanted to see if people who attended health checks at baseline, were they more healthy? And although it didn't seem like they were, we wanted to do a statistical check for that as well. And so we used e-value calculations, which are an approach to trying to measure how big an unmeasured confounder would have to be in order to explain the full result. And we found that an unmeasured confounder would have to be 2 times over and beyond what we've already measured in terms of confounding to explain the full result, which we thought was unlikely. But another limitation is that our data set didn't discriminate between cardiovascular deaths and all-cause mortality, and so that was just something to bear in mind. So this adds to the growing body of longitudinal evidence for NHS health checks, provides evidence support continued investment and the rollout of digital and workplace health checks, and also provides reassurance to policymakers and commissioners about its real-world impact. Now there's ongoing analysis on subgroups, so looking deeper into those different ethnicities and deprivations to see if there's any difference in mortality effects, but also looking at, instead of just looking at death as an outcome, looking at strokes or heart attacks as an outcome to see if it's impacting some of those end outcomes. We'd also like to combine it with local research to gain deeper insights, as overall we want to deliver a more equitable service of the NHS health checks to underserved populations. Thank you. That's the end.
Thank you so much for that, Jasjot, for your presentation. I was particularly interested in the geospatial mapping and how powerful it is to visualise the data. Also, many councils and organisations are in discussions currently to try and get R in their organisation. So to see the actual impacts of having R and the benefits it brings is absolutely wonderful. We do have some time now, though, to go through some of these questions that the audience have been asking. I'd now like to welcome back all our presenters. And we've attempted to chunk up some of the questions to try and get through as many as we can. But please do jump in, speakers, if there's more to add. And I'm happy for yourselves to allocate between that. So bear with me. I'm going to look at the most upvoted questions there. So the first one is, did you face any challenges in joining up, matching people over team-specific data sets? Did you use any specific tools to help? E.g., how were you matching health and non-health data?
Is that one for us, I think? Yeah, potentially. So we, in our linked data set, all our person level data is linked using NHS number. So we pull our adult social care data in and link to all the other health and social care data sets using NHS number. And I think somebody asked in the chat, like, how have you got some of this data at LSOA level? And the answer to that is, so for instance, if I just take anxiety diagnosis, we can see how many people have got an anxiety diagnosis. In our data set, we can see what lower super output area they live in, so we can aggregate up to lower super output area. And some of the other data, like fuel poverty, for instance, published nationally, are lower super output area. So it means that Kathryn was able to take those two LSOA values and kind of aggregate up together in those grids that she showed. Does that answer the question?
Thanks ever so much. The next question we have is, our HDRC is working with local authority officers to improve evaluation practice. As our internal research has revealed, evaluation is regularly A, tacked on at the end of projects as a justification exercise, or B, not done at all, particularly any form of impact evaluation. What resources have you found most useful for 1, generating buy-in to do more eval, and 2, evaluation training, and 3, planning, conducting and recording evaluations?
I can answer part of that, Mark, if that's helpful. I think they may have come in whilst I was speaking. So there's a couple of things to say. Firstly, your experience within your HDRC is very much not unique, and it's something that's shared by an awful lot of local authorities, and it will vary inevitably by directorate and by team. And we found in Oxfordshire that a lot of the requests coming into our research team have been for support with designing and implementing evaluations. In terms of actually specifically how we've managed to begin to engage with this, firstly, there's awareness that evaluations are valuable to service delivery and service design. So there's a kind of cultural information sharing kind of awareness point that has taken quite a long time. It started with a big cross-council needs assessment survey and lots of internal comms, which has meant that people are now asking about evaluations. That's a positive thing. The second point is, how do you follow that with money? So sometimes evaluations do cost money, and actually if you're going to do it properly, you build it into the financial plan at the start. So there's a shift in how we consider the value of evaluation and how it relates to what we might then do to invest to save in the future. So that conversation with finance and resources and with teams has taken a little bit of time as well. And then the third is your point on training and development. That's kind of a hard nut to crack. So we do have a repository of training skills resources that are available either nationally or locally that are free. So people, like basic online courses that you can click on and take part in. And we're also increasing our partnership with our local universities, Oxford Brookes and Oxford University, to share access to some of those courses, some of them free, some of them costed. However, one of the kind of core threads of the strategy is capability, and that is looking to develop a much more bespoke offer for training, both on research, so why is research important and why is it valuable in decision making, but also in some of the specific areas where there may be helpful for evaluation. And we've hooked quite a lot onto the recent sort of strategic commissioning ask in integrated care boards. So integrated care boards are being asked now more about how they can use population health management techniques to think about how they can commission more effectively to support prevention and tackling population health needs. And we're working very closely with our ICB on how we can support that programme as it develops, which includes population health management training, which we're making available to our local authority colleagues. So there's a little bit about how we're trying to do this across a system as well. So we haven't got a right answer to this, and I don't think anybody will have like, this is what you have to do type thing, but there will be a breadth, I hope, of opportunities in your place that will hopefully meet the needs, but it will take a look. For us, it's taken quite a while to get along that journey, and we're not there yet.
Thanks ever so much for that, Adam. The next question we have is, with the qualitative interviews, did you review the responses manually, e.g. a bunch of people reading all the responses and drawing conclusions, or did you have access to machine thematic analysis?
So we did do it manually, and that's not to say it's the right thing to do. One of the things we've invested in as a local authority is Microsoft Copilot and all the associated AI stuff that comes with it, and we're being hugely encouraged and supported in using that much more routinely in our day-to-day work. So my guess would be that would be our starting point to think about how we might do thematic analysis of large swathes of qualitative data alongside manual, and there'll need to be a bit of validation to check we're getting out what we want to. To be honest, with those community profiles that I was talking about and the qualitative work that came with it, a lot of that was done in real time, and so it wasn't a massive add-on in terms of some of the work that we were doing at the time. At least I didn't notice it as that. Some of the team might tell me otherwise. But moving forward, I suspect that Copilot and other AI tools will become a much more routine way of us, particularly when we've got large amounts of qualitative data to begin to interpret. We're certainly doing that with our routine documents and that kind of stuff at the moment.
Thank you, Adam. And we have a question for Suffolk next, which is, did you add any weighting for risk factors?
So we did, in a way, add weighting. So a couple of those indicators, we essentially repeated twice. We had a flag that gave individuals a note that said, do you have a mental health condition? And that included anxiety, depression. So the literature did specify that there are certain conditions that pose a higher risk factor. And in order to take this into account, we essentially repeated those indicators. So you'll see we have that mental health flag, we have the depression and anxiety separately put in there. So we could really pull that out. We've also done that on one of the other indicators that was highlighted by Shelter around overcrowding and how this actually impacts on people quite significantly. And overcrowding is included in our IMD indicator as well. So there you can see just that subtle way of adding an additional count towards an indicator help to that weighting. Now, there's no standardized format for suicide risk factors or the mental health. So it was a case of doing an ad hoc kind of weighting.
Thanks ever so much. Do have a question for Jasjot as well, and not familiar with this area. Would you class the effect size of health checks on mortality as small or large? Think there was a 3% decrease. How does that translate to population level outcomes?
Thank you. Yeah, so it's a good question. So it was a 33% relative decrease, but we also did some calculations to look at the absolute decrease by age group and found, not surprisingly, that the biggest absolute decrease was in the elder, over 65 population, and this was 4.4%. So what that actually means in like real terms is that in order to prevent one death in 10 years, you'd have to treat 23 people. So that was the calculation. So in a population level outcome, that's quite positive. And then we found for the youngest age group, the 40 to 54-year-olds, you'd have to treat 167 people, but that sort of makes sense because over the period of 10 years, you're going to have a much lower mortality rate in that age group. And so you'd have to treat a lot more people.
Thanks ever so much. The next question is an open question for everyone on this one, because I think it's quite universal. And this is really interesting to see people using R more within local authorities. We've had difficulty getting R and Python installed and operational within our area due to IT concerns around security. How are other areas overcoming this?
I can jump in first on that one, if helpful. So in terms of our IT have let us have that installed on our machines. So we have our studio. In terms of Python, no, we're not allowed to run that on our usual work laptops. The risk is a bit higher, I think. With Python, you could potentially do more with it. But what our IT have done is they've set us up a remote desktop, so like a virtual machine that we can use, which is more restrictive. So it means, you know, we can't take down the Suffolk County Council IT infrastructure in it, but they can open up connections as required. So they can open up connections to our data warehouse, for instance, allow us to install particular packages on there. So anything for Python, so that comes from pip or from R, you know, if it's in CRAN, whereas restrict ones which are, say, you have to go to GitHub to download. So I think have a conversation with your IT department, let them know why you need it, what you need to do. We had to do a business case to get the virtual environment set up, but have done that for us, and it's working really well. A lot of, you know, IT are coders as well, so can be quite sympathetic if you're quite clear on what the benefits are.
Thank you. And is there anything from Adam or Jasjot on this?
I can just add, so similarly, I think R was sort of, when I joined the local authority, R was sort of only just starting to being used. But in terms of going through sort of IT security, it was relatively quick to be set up, which was quite positive, as I think it was sort of being already used in some of the other sort of data departments in the local council. But I think the head of intelligence of Lambeth Council is on the call as well, so I don't know if he'd be able to give some more insights about how it was all sorted before I started. Thank you.
Great job landing them in it. Whilst they may be putting on their microphone, so in Oxfordshire, I can just speak to R, and we haven't had any issues with using it with our IT team. But with all this stuff, as everybody's emphasised, going through your IT team is essential, particularly if you're potentially uploading stuff to servers, because you can get very unstuck very quickly from a data protection perspective if you're not careful.
Thanks ever so much. And I think we've got time for one more question, if everyone's okay with that. The last question is the social care records example a linked data set in the country? If so, how have you agreed this linkage? And I think that was for Adam.
It was, and the answer is no, it's not. That particular analysis was only done using the social care data, which included data on hospital admissions, ongoing chronic diseases and mortality, but didn't include things like primary care and secondary care detail in terms of service use, etc.
Thanks ever so much. That was quicker than I thought. We probably can squeeze in one more question if everything's okay with that. So could you give some examples of the potential indicators identified for needing additional social care support and services? And I think that one was for Adam as well. Thank you.
That's me as well. Yeah, so I can give some of the macro stuff at least. As you might expect, age was the key predictor for all of this stuff, but there were some interesting things on different registered chronic diseases and the length of times that they've been in place for. And the nice thing that the machine learning algorithm was able to pull out was combining different measures and saying that, you know, once you hit a certain either pattern of different exposures from a medical perspective or from any other of the different characteristics or variables that are included in the model, you then get into a space whereby over a certain time frame you can predict what might be coming in terms of either care plans, hospital admission or mortality. And with the care plan and the mortality work, some of those predictors had quite a long lead time, which is where that prevention element really comes in, and it's where the conversations now with the teams about what we might be able to do from a preventive space in some of these areas, in partnership often with clinicians, becomes really live and real. The predictors for mortality were slightly closer, so that provides less of a window for doing things differently. I hope that helps a little bit. I'm sorry it wasn't super specific, but I don't want to preempt the peer review and whatever else might be coming forward. Thanks.
Thanks ever so much for that. So where do we begin to wrap all this up? We set out on this event to give the audience food for thought, another tool in the box, enhancing data capabilities, also raise awareness of data in public health. If you do find these topics useful, please do reach out to us, join our communities, get involved. There's a ton more that the LGA is doing more widely in data science, and we're here to find the information you want. We will put a webinar up for the topics that you're interested in. A big thank you to all our speakers today. Not only have they given up their time to present today, but they've also been leaders in the sector, which is great to hear from people so passionate to make a difference. Thank you also to everyone attending this afternoon as well. If you're watching this from record, please do keep an eye out for the event so you can join in the discussions. And these slides will go out to everyone afterwards, and have a lovely day. Thank you very much.